It is 2 in the morning in StAMPSville. A mother carries her 18-month-old daughter into your emergency department. The little girl has had fever since yesterday afternoon, and in the last 2 hours the mother has noticed dark spots spreading across her trunk and legs. They do not fade when she presses them. The child is flushed, breathing fast, and cries inconsolably when you approach.
Stop there. This is a presentation where hesitation kills. A toddler, high fever, and a non-blanching rash in a town of 4,000 people, 300 kilometers from the regional hospital, with an aircraft 90 minutes away. The next 60 minutes belong entirely to you. Every rational decision you make now is the difference between a survived infection and a coronial case.
Good morning. It is Friday the 15th of August. This is StAMPS Daily. 90 days until your CGT StAMPS examination. Phase 1, Foundation. Today we take on the highest stakes pediatric presentation in rural generalist practice. A febrile child with a non-blanching rash and the possibility of meningococcal disease.
And we build it the way the college expects. First, the clinical substance. What the rash actually means, how to separate the well from the seriously unwell, and exactly which drug at which dose, by which route. Then the rural reality, no intensive care, no pediatrician, a mostly nursing team around you. Then the examiner lens, how this scenario is scored.
Let me signpost the episode. Part 1, Decoding the rash and the structured assessment of the febrile child. Part 2, Definitive management, sepsis resuscitation, retrieval, public health, and how to perform it under examination conditions. We close with rapid recall and a one-line summary you can carry into the exam.
Before we start, one framing point. The Royal Children's Hospital guideline is blunt about this. The majority of children with fever and petechiae do not have a serious bacterial infection, and often no specific cause is ever identified. But serious bacterial infection, including meningococcal disease, can present exactly this way, with or without fever.
So the clinical task is not to panic and it is not to reassure. The task is to run a structured assessment that reliably separates the child who needs resuscitation and antibiotics within the hour from the child who needs careful observation and review. That discrimination is the whole game.
Start with the rash itself. What exactly are we looking at when we say non-blanching?
Petechiae are pinpoint, less than 2 mm, non-blanching spots. Purpura are larger, greater than 2 mm, non-blanching lesions. The test is simple and you should describe it out loud in the exam. Press the rash with a finger or a clear glass. Blanching spots fade under pressure. Petechiae and purpura do not.
And here is a trap the examiners love. Does a blanching rash exclude meningococcal disease?
No, and this is documented explicitly in the Royal Children's Hospital guideline. The meningococcal rash can begin as a macular or maculopapular rash that does blanch, and only later evolve into the classic purpura. So the message is, a blanching rash lowers concern but never turns off your brain. The overall state of the child drives the decision.
Which brings us to the differential. Before you commit to meningococcus, what else causes fever with petechiae or purpura in a toddler?
Infective causes first. Invasive meningococcal disease is the killer we must not miss, but pneumococcal bacteremia and other serious bacterial infections sit on the same list. Viral infections are the commonest explanation overall, including enterovirus, adenovirus, influenza, and the classic viral exanthems. Since routine vaccination, invasive pneumococcal and meningococcal disease have genuinely become less common.
Keep going. Non-infective causes.
Trauma, including non-accidental injury, so ask about and examine for that. Vomiting or coughing fits can produce petechiae above the clavicles, a mechanical pattern. Thrombocytopenia, including immune thrombocytopenic purpura, leukemia, and other hematological disease, vasculitis, such as Henoch-Schönlein purpura, and rarely clotting disorders.
Before you leave the differential, explain to me why meningococcal disease makes this rash at all. Understanding the mechanism changes how you monitor it.
The organism invades the bloodstream and multiplies, and its endotoxin drives both systemic inflammation and direct vascular injury. The organism lodges in small dermal vessels, where inflammation and thrombus formation produce the pinpoint infarcts we see as petechiae, and as the process intensifies, adjacent lesions merge and the spots enlarge into purpura. In severe disease, the same process consumes platelets and clotting factors, which is disseminated intravascular coagulation, and the purpura can progress to areas of frank necrosis.
And that mechanism gives you a monitoring instruction. What does spreading purpura actually tell you at the bedside?
It tells me the process is active and evolving, which is why the guideline names rapid progression as a high-risk feature. In practical terms, I map the rash, I take a photo with consent, or mark the edges of the involved area with a pen, and I recheck at every reassessment. A rash crossing my pen lines between observations is disease on the move, and it stiffens my resolve on early antibiotics and early retrieval.
That pen marking habit is a lovely, concrete, rural detail. It costs nothing, requires no equipment, and it converts a vague worry into data. Now flip the scenario for a moment. Same age, fever, a handful of stable petechiae on the chest, and the child is running around the department chasing a toy. What happens to that child?
That child is in a different category. The guideline is explicit that the majority of these children do not have invasive bacterial disease, and that a careful assessment can support a less invasive pathway. That child still gets a full structured assessment, senior review, and a documented plan, but the well child with a stable rash may be managed with observation and targeted investigations rather than the full sepsis bundle.
And if you discharge that well child, what must never be left unsaid?
Safety netting, and the guideline words it precisely. Always advise parents to return for review if their child becomes more unwell or if there is any concern. In StAMPSville, I make that concrete. I say if the rash spreads, if she becomes drowsy or floppy, if she will not drink, if the fever will not settle, you come straight back day or night and you do not wait for an appointment. I write it down, and where the family prefers, I ask the Aboriginal health worker to reinforce it in language that fits.
And one more distinction for the running around child. Give me 2 examination findings that would move that child back towards the worrying end, even if the behavior looks good.
A toxic or lethargic interval, a child who plays, then crashes and stares, and slow capillary refill, cold peripheries, or tachycardia out of proportion to fever. Behavior is one data stream. Perfusion and physiology are another, and physiology wins the argument.
And the examination findings that point you towards the haematological causes rather than infection?
The guideline tells you to look for hepatomegaly or splenomegaly, lymphadenopathy, and swelling or erythema of the joints. A child with purpura, pallor, and a big spleen is a different problem, and in StAMPSville, with formal bloods only couriered 3 times a week, that distinction may ride entirely on your hands.
Let us put you back in the department. The child is on the bed. Give me the structured assessment, out loud, the way you would say it in the exam.
I assess in this order: airway, breathing, circulation, disability, and temperature. Then a focused history, then a full examination, then targeted investigations. I signpost that order deliberately, because in StAMPS structure is visible and it is scored.
Airway and breathing first. What are you actually measuring?
Work of breathing, respiratory rate against age-based normals, oxygen saturation in air, and auscultation. Tachypnea is one of the guidelines markers of the unwell child. Desaturation in air is another. In our toddler, fast breathing with fever could be compensation for shock, early sepsis, or a primary respiratory infection, and I hold all 3.
Circulation. This is where the exam lives or dies. Talk me through shock assessment in a small child.
I assess heart rate against age normals, capillary refill, peripheral temperature, pulse volume, and blood pressure. The guideline splits shock into 2 patterns, and this is a beautiful piece of physiology to articulate. Cold shock, narrow pulse pressure, cold clammy extremities, prolonged capillary refill, weak pulses, the vasoconstricted child. Warm shock, wide pulse pressure, bounding pulses, flushed skin, rapid capillary refill, the vasodilated child.
Why does that distinction matter at 2 in the morning in a town with no doctors on the ward?
Because warm shock fools people. A flushed, warm, bounding toddler looks better than they are, and the complacency kills. And the critical teaching point: hypotension is a late and pre-terminal sign in children. Children compensate. A normal blood pressure does not mean the circulation is fine. It means the child is still compensating.
Say that last sentence again, slowly, because it is worth an entire station.
In pediatric sepsis, a normal blood pressure is not reassurance. It is a child still spending their reserve. By the time the pressure falls, you are behind.
Disability and conscious state.
The guideline is specific about what counts as altered conscious state. Irritability, meaning inconsolable, crying or screaming, and lethargy, including lethargy reported by the family. In our scenario, the child cries inconsolably when approached. That single phrase is a red flag, and it came from the mother's observation as much as my assessment.
And one more from the guidelines unwell list that candidates routinely forget.
Limb tenderness or difficulty mobilizing. In meningococcal disease, limb pain can be a prominent early feature, and in a toddler it shows as refusing to walk or bearing weight, or distress on handling a limb.
So the unwell child is defined by abnormal vital signs, signs of cold or warm shock, altered conscious state, and limb tenderness. Now the history. What are you asking this mother at 2 in the morning, and why?
Timeline first. When did the fever start? When did the rash appear? And critically, how fast is it evolving? The guideline flags rapid onset and rapid progression of symptoms and rash as high risk. A rash that was 3 spots at midnight and is now covering the legs by 2 is a different creature from a stable handful of spots present for 2 days.
Immunization status. Why does the guideline care so much?
Children under 6 months of age, or with an incomplete immunization schedule, are a designated high-risk group, and in StAMPSville, this is not a box-ticking question. Around 35% of our district is Aboriginal and Torres Strait Islander, and we will return to why that changes both risk and prevention later in the episode.
What else on the history must you capture?
Recent antibiotics, because prior treatment can mask the signs of bacterial infection, immunosuppression or previous invasive bacterial infections, trauma, which opens the mechanical and non-accidental injury pathways, bleeding, abdominal pain, joint pain, and difficulty mobilizing, which point to haematological and vasculitic causes, travel, and sick contacts, which matters both for diagnosis and for the public health actions that follow.
Notice what he just did. Every item on that list is from a single national guideline, and every item earns marks, because it narrows the differential in a way the examiner can follow. Now, investigations. The aircraft is 90 minutes away and your pathology is a point-of-care machine. What do you actually order?
In StAMPSville, my point-of-care capacity is biochemistry, blood gas, hemoglobin and hematocrit, INR and troponin. So in the shock child I take a venous or arterial gas, which gives me lactate, glucose and acid-base status in minutes. Lactate above 3 millimoles per liter is one of the Royal Children's Hospital escalation criteria. INR matters because coagulopathy, and INR above 1.6 is another.
Blood cultures. There is a rule about blood cultures here that you must say exactly right.
Collect blood cultures prior to antibiotics if possible, but never delay antibiotic administration. Say it that way, in that order. In StAMPSville, culture bottles go with the retrieving team. The result will never come back to me, and it does not need to. My job is the first hour, not the 5th day.
And the tests you cannot do. No full blood count instantly. No formal coagulation panel tonight. No CT. How do you talk about that limitation without sounding defeated?
You name it and you route around it. I cannot get an urgent full blood count and differential in StAMPSville, so my decision thresholds are clinical, guided by the point-of-care gas, hematocrit and INR. There is no CT, and in suspected meningococcal disease I do not need it. This disease is diagnosed clinically and confirmed by culture and polymerase chain reaction at the receiving hospital.
That last answer is a fellowship-level answer. You acknowledge the constraint, you stated the workaround, and you did not apologize for the town you work in. Let us finish the assessment. The toddler before you, flushed, tachypnoic, inconsolable, spreading purpura. Where is this child on your risk stratification.
This child is unwell by multiple guideline criteria: altered conscious state with inconsolable crying, abnormal vital signs with tachypnoea, and a rapidly evolving purpuric rash in the context of fever. I am treating this as probable invasive meningococcal disease until proven otherwise, and the clock started at the door.
That decision is the pivot of the entire episode, and it is where part 1 ends. When we come back, the drug, the dose, the route, the fluids, the retrieval call, the public health cascade, and the vaccination story that makes this personal for StAMPSville.
Quick recap before the break: petechiae under 2 mm, purpura above. A blanching rash does not exclude meningococcal disease. Hypotension is late. Inconsolable crying is altered conscious state. Cultures if possible, but antibiotics without delay. And the child in front of me meets multiple criteria for unwell.
Hold all of that. Part 2 is where we make you dangerous, in the best possible sense.
Our toddler is on the bed, assessed as probable invasive meningococcal disease. The clock is running. The first question is not clever. It is, what is the order of actions, and what exactly do you give?
And I want it in the order the Royal Children's Hospital sepsis guideline gives it, not the order you remember from a textbook. Structure is visible, and structure scores.
The sequence is this: early recognition and calling for senior help, assess airway and breathing, and give oxygen if required, rapid vascular access, empiric antibiotic therapy, carefully titrated fluid resuscitation, early inotropes if shock persists, early involvement of critical care and retrieval, source control, and frequent reassessment.
In StAMPSville, calling for senior help means one thing, and it is not a registrar down the hall. It means you say out loud to the nursing team, I am worried this child has meningococcal sepsis. I need the resuscitation protocol activated now. Who is actually in the building with you at 2 in the morning?
Nurses, remote area nurses, possibly an Aboriginal health worker. There are no resident medical officers, so the call out matters because it converts me from a lone doctor into a team with tasks. 1 nurse on the airway and monitoring, 1 on access and bloods, 1 on the phone to retrieval. Roles allocated in the first 60 seconds.
Vascular access. The guideline has a number attached to this. What is it?
15 minutes. If intravenous access cannot be obtained within 15 minutes, the antibiotic goes intramuscular or intraosseous. In an 18-month-old with shock, veins vanish. So I say early in the exam I will attempt access once, briefly, and I will put the intraosseous needle in my hand at the start of the attempt, not after 3 failures.
Now the question I ask every candidate, and I will ask you, what exactly are you giving? Drug, dose, route?
Ceftriaxone, 50 milligrams per kilogram up to a maximum of 2 grams, intravenously. If I cannot get intravenous access, the same dose intramuscularly. The intramuscular route is acceptable because this is a weight-based pediatric dose, and I would document the weight I used and the dose given.
Sources, please. Where do those numbers come from?
The South Australian Health Guidance on Invasive Meningococcal Disease for Health Professionals, which gives ceftriaxone 50 milligrams per kilogram up to 2 grams, intravenous or intramuscular, as acceptable empirical treatment before transfer, and the Royal Children's Hospital Acute Meningococcal Disease Guideline, which says intravenous ceftriaxone or cefotaxime as soon as the disease is suspected.
Alternatives. Suppose your fridge has no ceftriaxone. Say the next sentence without pausing.
If ceftriaxone or cefotaxime is unavailable, I give benzylpenicillin, 60 milligrams per kilogram up to 2.4 grams, intravenously. And if the child has true immediate penicillin hypersensitivity, ceftriaxone remains suitable, because immediate hypersensitivity to penicillin is the one group South Australian Health carves out. Cefotaxime, 50 milligrams per kilogram up to 2 grams, 6 hourly, is the other cephalosporin option.
One practical detail from the Royal Children's Guideline about the intramuscular route in a small child.
The dose may need to be split into 2 injections because of volume and muscle size, and repeated once intravenous access is available. Say that in the exam, and you demonstrate you have actually given a pediatric intramuscular injection, not just read about one.
Fluids now. This is where rural candidates lose marks by reciting adult habits. Bolus, volume, fluid type, reassessment.
A bolus of 10 to 20 milliliters per kilogram of sodium chloride, 0.9%, as fast as possible, and I reassess the circulation after every single bolus. The Surviving Sepsis Campaign pediatric guidance suggests buffered or balanced crystalloids, such as Hartmann's overplain saline, with saline a reasonable alternative, and for a child with possible central nervous system infection, I am comfortable with saline.
Thresholds. When does senior help get involved? And when do inotropes enter the conversation?
At 20 milliliters per kilogram total, involve a senior clinician. In StAMPSville, that is the retrieval consultant on the phone. At 40 milliliters per kilogram, inotropes should be considered, and the Royal Children's Guideline lists shock persisting despite 40 milliliters per kilogram inotrope requirement, lactate above 3, and coagulopathy, with INR above 1.6 as escalation criteria for pediatric intensive care.
Adrenaline. Where, how, and this is the sentence people do not believe until they have said it in an exam.
Inotropes and vasopressors may be given safely through a peripheral cannula or an intraosseous needle during initial resuscitation in children. I do not need central access to start an adrenaline infusion in StAMPSville. I need a phone call to Retrieval, a dilution plan, and a nurse assigned to the syringe driver.
And that phone call. The aircraft is 900 kilometers away, roughly 90 minutes of flight, and there is no helicopter. When do you call?
At the moment I suspect the diagnosis, not when I have finished stabilizing. The call itself takes 90 seconds and runs on a structure. I am the doctor in StAMPSville, 18-month-old, fever and rapidly spreading purpura, probable meningococcal septicemia, heart rate 180, capillary refill 4 seconds, blood pressure still normal but compensation narrowing. Ceftriaxone given at this time, 10 mils per kilo saline in. I need pediatric retrieval and I need advice on the next hour.
Notice the elements: age, diagnosis, physiology, etiology, treatment given, and a specific request. That is an SBAR handover, situation, background, assessment, recommendation, and you have just shown the examiner the teamwork domain without being asked.
There is a hard truth in that call. 90 minutes of flight means the aircraft lands 3 hours after the child walked in. So the first hour of pediatric septic shock resuscitation in StAMPSville is nursing, and me, on the phone, executing a plan we narrate out loud. That is the job. The exam is testing whether you can lead it calmly.
Which raises delegation. Who is doing the observations, and how do you make sure nothing is missed?
I allocate continuous monitoring to one nurse with a verbal escalation threshold. Any deterioration, call me to the bedside immediately. I set my own reassessment rhythm, formally at least every 15 minutes in the shocked child, and I say when the next review is and who is chasing every result. In a small team, unfinished loops are where patients die.
Blood products. You have 4 units of O-negative packed cells and nothing else refrigerated. When do they get used here?
Only in refractory hemorrhage from disseminated intravascular coagulation, and ideally after discussion with Retrieval, because in sepsis the problem is usually distribution, not volume of hemoglobin. I would say in the exam my blood inventory is 4 units of O-negative cells. I am holding them for circulatory collapse with uncontrolled coagulopathic bleeding, and I have flagged that limitation in my Retrieval call.
Now the questions that separate fellowship candidates from passing ones. Lumbar puncture. Do you do one?
Not in this child, not now. The child is shocked, and lumbar puncture is contraindicated in shock, in coagulopathy, and in altered conscious state with raised intracranial pressure concerns. The Royal Children's Pathway defers cerebrospinal fluid sampling until the child is stabilized, and in StAMPSville that means the receiving hospital does it, guided by culture and meningococcal polymerase chain reaction.
Steroids. The classic Viva question. Dexamethasone before or with antibiotics in suspected meningococcal disease.
In this child, the priority is antibiotics and resuscitation, and I would not let steroids delay them by a second. Adjunctive dexamethasone has a role in pneumococcal meningitis, and if the retrieved child proves to have meningitis, the receiving team will make that call with cerebrospinal fluid in hand. My honest exam answer is, not in the pre-retrieval hour in StAMPSville, and here is my reasoning.
Good, because a candidate who volunteers a reasoned no, rather than a reflexive yes, reads as a safe clinician. Public health now. The child is stabilizing. What happens in the next 24 hours that has nothing to do with the child?
3 cascades. First, notification. Invasive meningococcal disease is notifiable, so I notify public health and the receiving hospital the same day. Second, contact tracing and prophylaxis. Household and household equivalent close contacts need clearance antibiotics, and that conversation is delicate because it happens while the family is terrified.
And the third cascade is the one examiners reward you for thinking of unprompted.
The community. StAMPSville has 4,000 people, around 35% Aboriginal and Torres Strait Islander, and a case of meningococcal disease in a small town is a community event. I would work with the public health unit and Aboriginal health workers on clear, calm communication, and I would expect fear, rumor, and a surge of worried families into the emergency department over the next week. Planning for that surge is part of my job.
Let us give the vaccination story its own minute, because it is where prevention, equity, and the StAMPSville profile intersect. What does the data actually say about risk in Aboriginal and Torres Strait Islander children?
The National Center for Immunization Research data from 2016 to 2019 shows notification rates 3.5 times higher in Aboriginal and Torres Strait Islander people overall, nearly 10 times higher in children under 5, and 20 times higher in children aged 5 to 14. Hospitalization rates were 3 times higher overall. This is a disease of inequity, and in our district that is the background risk I carry into every febrile child.
And what does the Australian Immunization Handbook recommend for that population?
All Aboriginal and Torres Strait Islander people from 2 months to 19 years are recommended to receive both the meningococcal ACWY vaccine and the meningococcal B vaccine. On the National Immunization Program, ACWY is funded for all children at 12 months and adolescents at 14 to 16, and meningococcal B brand Bexaro is funded for Aboriginal and Torres Strait Islander children under 2 years.
Serogroup context, 1 sentence.
Meningococcal B remains the dominant serogroup in Australia, 83% of notifications in 2022, so Bexaro coverage in our under 2 population is one of the highest value prevention programs this town can run.
The child is intubated by the Retrieval team and airborne to the regional hospital. Fast forward, 90 days from your exam, walk into the station. The examiner says, Toddler, fever, non-blanching rash, StAMPSville. Take me through your opening 60 seconds.
I would say, my immediate priorities are airway, breathing, circulation, and early antibiotics. This child meets criteria for a seriously unwell child with probable meningococcal disease, so I am running the sepsis pathway. In the first 60 seconds I allocate team roles, apply monitoring, give oxygen if hypoxemic, and task someone to draw up ceftriaxone 50 mg per kilogram, maximum 2 grams, while I take a gas and attempt to access once, with intraosseous ready at 15 minutes.
Now the examiner leans in. The culture is negative. Was all that necessary? Defend your decision.
The majority of children with fever and petechiae do not have meningococcal disease, and I accept that most of the children I treat this way will have a viral illness, but the guideline is clear that this presentation can be meningococcal disease, and the cost of a missed hour is catastrophic and irreversible. I treated the child in front of me, who met multiple unwell criteria. I would do it again tonight.
That answer has 3 fellowship properties. It knows the base rate, it states the threshold, and it owns the decision without defensiveness. One more challenge. The mother refuses transfer. She has family in town, she is frightened, and she says her child always recovers from fevers.
I would sit down with her, and with an Aboriginal health worker or family member she trusts if she wants one. I would explain the illness in plain words. The infection is in her daughter's blood. The antibiotic has started, but the next day carries real risk, and the safest place is the regional hospital with the aircraft we have already called. I would address her fears about leaving country and family directly, because they are legitimate. If she still refuses while the child lacks capacity and is at grave risk, I involve the child protection and guardianship framework, and I document carefully, and I keep the door open, because that relationship outlasts this night.
Notice Notice that answer travels through communication, cultural safety, ethics, law, and continuity. 5 scored domains in 90 seconds. That is what a fellowship answer sounds like. Rapid recall now. I ask, you answer, no preamble. Petechiae versus purpura.
Petechiae are pinpoint non-blanching spots under 2 mm. Purpura are non-blanching spots over 2 mm.
Does a blanching rash exclude meningococcal disease?
No. The rash can start macular or maculopapular and blanch, evolving to purpura later.
Empirical antibiotic, pre-transfer, a toddler over 1 month.
Ceftriaxone, 50 mg per kilogram, maximum 2 grams, intravenous or intramuscular.
No ceftriaxone in the fridge.
Benzylpenicillin, 60 mg per kilogram, maximum 2.4 grams intravenously. Cefotaxime, 50 per kilogram, max 2 grams, 6 hourly is the alternative.
Fluid bolus.
10 to 20 milliliters per kilogram saline, 0.9%, or a balanced crystalloid. Fast reassess after each bolus.
Senior help and inotrope thresholds.
Senior involvement, at 20 milliliters per kilogram, inotropes considered at 40, and inotropes may run peripherally or intraosseously.
Lumbar puncture in the shocked child.
Contraindicated now. Deferred until stabilized, done by the receiving hospital.
Meningococcal B vaccine, who is funded.
ACRRRM, funded for Aboriginal and Torres Strait Islander children under 2, recommended for all Aboriginal and Torres Strait Islander people 2 months to 19 years.
And the sentence of the day.
In pediatric sepsis, a normal blood pressure is not reassurance, it is a child still spending their reserve.
90 days out, that sentence, and the 60 seconds that follow it, are yours. Tomorrow we stay in the foundation phase and move to pregnancy, with hypertension in the remote setting. Until then, this has been StAMPS Daily. Practice the words, and we will hear you tomorrow.
This episode is independent exam preparation. It is not endorsed by the college, and it does not predict exam content. Doses and thresholds were drawn from the Royal Children's Hospital Clinical Practice Guidelines, South Australian Health, the Australian Immunisation Handbook, and the Surviving Sepsis Campaign Pediatric Guidance. Check current versions before you treat a real child. See you at D-89.